And Lena, how's the other ones going? It's been
Oh, pretty good. You know, we've had, you know, they've been kind of up and down in terms of the participation, but we're recording everything and we're giving CME and we're putting them all on our website. So you need to know that they'll be there for enduring CME for a year.
oh good.
And I think that the speakers have all been outstanding, and I'm sure your speakers are going to be outstanding. And they're regionally focused. Earlier today, we had the Texas, 3 chapters from Texas, talked about
Excellent.
the border. Mainly El Paso and Rio Grande Valley were the focus. With
That
COVID,
that must have been
it's
fascinating.
just
Yeah,
been horrendous. Yes,
they've got hit hard.
yeah. But all of our communities have lessons learned that we need to document, and I know you have a lot of research that you're going to share, and I think that's
Yeah.
fantastic.
And Elena, have you gotten a sense on, or maybe NHMA is already working on education around the vaccine? I know Julia, that's near and dear to Julia, Dr. Garcia Diaz's heart.
Yeah, I'll mention it right now when we welcome, on the welcome. Okay, Ben's saying we should get started. Ben, do you want to? So I'm Dr. Elena Rios, President and CEO of the National Hispanic Medical Association. It gives me great pleasure to be here with our colleagues from the Gulf Coast, from the Ochsner Hospital System and the 3 medical schools in New Orleans area. And I just wanted to say a couple of welcoming remarks. One is, as we talk about COVID-19 throughout our chapters and what our chapters have been witnessing, and actually our doctors and medical students and public health officials have all been working together in different regions to find strategies for their patients and for people that are not going to care but are working 2 jobs. I mean, we have horrendous stories, but lots of experience and strategies from our communities. And that's what all of our chapters are sharing. I'd like to just say that at NHMA's office in Washington, D.C., I've been a part of the U.S. Department of Health and Human Services Vaccine Consultancy Committee under the Assistant Secretary of Health. We've also been invited to the Office of Minority Health convening with the Morehouse School of Medicine. You know, actually got $40 million to set up an infrastructure. I'm on a steering committee for them. And we've also been invited to the NIH for an understanding of some of the community engagement. And I know that they sent out, awarded several grants to different states and academic institutions in certain states to start focusing on community engagement and research around community engagement to prepare for the vaccines. And I want to encourage everyone on the call to let your patients know and your families know, your colleagues know that there are at least, you know, probably a dozen pharmaceutical companies out there in different stages of clinical trials. But there are 2 websites here that we are engaged with. The first one is the NIH website, working with Moderna. It is www.coronaviruspreventionnetwork.org. They are halfway through their 30,000 goal of enrollment, and they are actively looking for diverse patients. And I know they're having a hard time, just like, you know, everything else with healthcare. Our Hispanics and African Americans are the last ones to go to enroll. And the second website is from Pfizer, one of our partners, COVID vaccine study number 1.com. And then the other thing I just wanted to mention, the National Hispanic Medical Association has a foundation, has a scholarship program for students that are committed to working in Latino communities, who have been outstanding students and who are leaders, can document their leadership. And they are medical students, public health, dental, nursing, pharmacy students, and physician assistants. And we will be having our event virtually November 19th. It actually is going to be free with a donation requested, but we are inviting the Surgeon General to be awarded, and I think he's going to make it. And we have others from around the country being awarded. The invitation is going to be going out soon, if not tonight, tomorrow. And our national conference is March 17th through the 20th. It's also virtual. Our agenda is almost complete. We are looking for speakers. Again, we were talking about the opportunities that NHMA has for those who are interested in advancing their career by being a speaker at a national conference. We also have posters for faculty and students, and we have an exhibit hall to share information to advance careers in healthcare. But our goal is to help improve the health of our communities, and with that, I just want to turn it over to our new Gulf Coast chapter leader, Leonardo Suwani, and he will introduce his colleagues. And thank you for doing this, Leo.
Oh, thank you, Dr. Rios, and yeah, it's easier to go Leo. I've been Leo a long time, and appreciate it. It's really exciting to be one of the new chapters in the Gulf Coast chapter, in particular. Got a fantastic lineup for you tonight. Dr. David Smith from LSU. As Dr. Rios mentioned, there's 3 med schools in New Orleans. Dr. Julia Garcia Diaz, who runs our medical student research and infectious disease experts, we're running all our COVID research trials. Dr. Dodd Denton, who is our Associate Dean of Student Affairs for the Oxford Clinical School, the University of Queensland Oxford Clinical School, and is going to speak to us a bit about how the medical school adapted to the new COVID reality. And then I would like to just thank everyone for being on and just give a little bit of an overview on prevention and the latest data and science about how we can stay safe from COVID. So next slide. So to claim your CME credit, Dr. Rios said this will be recorded and it'll be available up to a year. So you can tell your colleagues who may not have been able to join us tonight, they could still log on and get their, and watch it and get their CME credit. Next slide. And so there's my objectives. So I said we're going to focus on prevention. We're going to talk about masks, vaccines, and antibodies, and all around prophylaxis and prevention. Next slide. So one of the controversies early on, there's been a lot of controversies about SARS-CoV-2, and I think we always got to take a step back and realize that this disease has been on Earth since December of 2019. It is a really new disease, and we are learning really fast. And one of the early controversies was it aerosol or droplet, and it's been back and forth, and I thought this study was a really good study to demonstrate how it is aerosolized, and the latest CDC has finally stated it's aerosolized. And then while 6 foot is a nice idea, 6 foot will not really protect you if you're not wearing a mask. And if someone speaks loudly, as there's now more and more data, sings, of course, coughs. So what they did here was basically take air samples. This was a COVID ward. That's why you see 2 patients in close proximity. Both patients had COVID. They set up air samples around the room, and they were able to pick up live virus at 7 feet and 16 feet. Neither of the patients were submitted to aerosolized procedures. So these weren't patients getting nebulized treatments or anything else to stimulate cough. Next slide. So another interesting concept that comes around if we say, hey, 6 feet is not a magic number, and really masks, and what are the roles of masks? And unfortunately, masks were politicized because Mask wearing, now there's very good data, now that we have a lot more experience with disease, that masks work. And there's a couple of concepts I want to introduce you and to give you some data around masks. One is that masks could lead to milder symptoms and more asymptomatic cases. They, even beyond prevention, even because we know that masks aren't 100%, but even if they're not 100%, there's some data that says that, hey, the mask may actually decrease the viral load. And there's an evolving concept with COVID that the viral load is important as well as host factors as to how sick someone gets when they get uh, uh, infected with COVID. And so there's a COVID hamster model demonstrating increased severity with increased inoculum. And then there's multiple case series of increased asymptomatic cases when there was an outbreak and others that were in that area were exposed, but they had their masks on. So this is beyond two people wearing a mask. And early on we said, wear a mask for yourself, but more importantly, wear a mask for your fellow man or woman and to protect them. But we now know it also protects you. So this was on a cruise ship, food plant, hospital wards. There's all been literature demonstrating that if you had a mask on when there was an outbreak, you had more asymptomatic cases than would be expected. And therefore, this idea that you could decrease population death rates with mask wearing and actually get to herd immunity without the severe cases. Now, that is a bit of a stretch, but I think the overall message is that we're developing more and more data to say that protective for you wearing a mask may not just prevent you from getting the illness, but if you do get it, that it'll be less severe. Next slide. And I think that's important. And we've done two prevalence studies. Oxford did a prevalence study in New Orleans on May 15th, before there was a mask mandate, but there was a stay-at-home mandate. And then we also did a prevalence study in Baton Rouge. These are the two largest cities in Louisiana in July 15th, after there was a mask mandate. And I showed this slide. This shows the Baton Rouge prevalence slides. We did two things in our prevalence study. We did a PCR sample of the nasopharynx to test acute active cases. And then we did serology tests with the Abbott serology study to detect IgG and past infections. And then there was a period there where you could be positive by PCR and not develop the antibodies yet. And so those are the PCR positive, antibody negatives. That were very likely to be infected. And what we found in this overall group is that those, even before they mounted an immune response, about 70% of patients were asymptomatic, actively shedding virus and asymptomatic. And overall, all of the patients, that, including those that had previous exposure, was around 60% asymptomatic. When we compared that to our New Orleans prevalence study, we found about 40% of patients asymptomatic versus 70%. Now, this is not cause and effect, but along with that interesting concept that wearing a mask may give you a lower inoculum and therefore present with more asymptomatic cases, it's an interesting finding that our temporal time of our prevalence studies, one when there was a mask mandate and one when there wasn't, we found significantly more asymptomatic cases. Next slide. And then further data to show the impact of masks is this wonderful case series reported by the CDC of two hairstylists in the Midwest. All of them were symptomatically infected, but like many people know, they could not get tested and they still had to work. So even though they were having symptoms, they went in every day and they were stylists for their patients. And they all spent more than 15 minutes symptomatic with a mask on. Now, in their rules, in their workplace, the patients had the clients had a mask and they had a mask. So both were wearing masks. They cared for 139 clients before they finally were able to get their COVID test, and they were both positive. Symptomatic, COVID positive, 139 clients, both wearing masks. Not one of their clients seroconverted and became infected. Just more data, the power of the mask. Next slide. And then last slide to kind of support mask is this efficacy of mask mandates and states. So this looks at states and different policy in that state. And so mandatory states that had mandatory mask policies versus states that just required patrons and employees of certain businesses to wear masks versus states that had only employees in certain businesses to wear masks, not even the patrons. And then those states that just recommended masks, but did not have a mandate. And as you can see, significantly higher cases per million in those that just recommended. So having legislation that mandates masks is effective. That's a big controversy, unfortunately, in Louisiana, as many of our Republican legislators have tried to, and are actually running a special session to try to overrule the governor who currently has a mask mandate in Louisiana. Next slide, please. And then last on masks, not all masks, face masks are created equal. This is a very nice study that was done by our Duke researchers that looked at particles in different masks. You wouldn't be surprised to learn that the best mask was the N95, closely followed by the surgical face mask. And the one mask that was actually not only not effective, but potentially worse was the gaiters. And those are those neck masks that people pull over. And actually what they did is they aerosolized and dispersed the particles further than any of the other masks. I find this important and use this a lot to educate my patients about, especially my higher risk patients, that they should be wearing the surgical mask. Next slide. Then I want to move and just touch a little bit about vaccines and just kind of latest update on that. There's about 130 different candidates for vaccines reported, 44 of those in clinical trials. Now, the majority of those vaccines are against the spike protein on the virus. There are many different ways that we can create these vaccines. Some have a viral vector, like the adenovirus, and I'm going to talk about two of those that have recently, one that's currently paused and one that's had a previous pause due to side effects. Protein-based by giving it a backbone, the DNA, the RNA particle. And then the new vaccines, which are the DNA and RNA type vaccines on the lipid moiety. Next slide. And for those who just want to track this, actually the New York Times has an incredible tracker that really tracks the latest vaccines. And this is as of October 7th, so just about a week ago. You can see 92 in the preclinical stages and the animal model stages, 29 in phase 1, including the University of Queensland, who I mentioned because that's one of our academic partners at Oxford that has a protein-based vaccine. In phase 2, there's the Johnson & Johnson, which is the Janssen vaccine. That was just set to start in Louisiana. In fact, Oxford was one of their sites. For those who've been following the news, that's one's been paused. That is a viral adenovirus vector mediated vaccine. It was in a combined phase 2-3 trial. On the phase 3 side, you'll see 3 big ones, the Oxford AstraZeneca, which also had been put on pause and currently still on pause in the United States, but active in Great Britain and other parts of the world. It's another adenovirus vector vaccine. And both of those have been on pause for safety, more safety work. And then Pfizer and Moderna, which are both mRNA vaccines, are well on their way in their phase 3. Pfizer has over 30,000 patients enrolled, and so does Moderna. So, And then there's these limited approvals that have been out there. I really like the name of the Russian vaccine, the Sputnik 5. I think that's pretty catchy. But I think everybody realizes that on these limited approvals, they have skipped steps. These have not completed a robust phase 3 efficacy and yet are now being actually given to people in limited basis in both China and Russia. Next slide. And then last, I just want to talk about what's, thanks to the president, has been on the media. So I figured I'd just touch on it. And these are monoclonal antibodies. There's two out there in the market currently or being studied. One is by Regeneron, which is what the president got, and the other is Lilly. These are humanized monoclonal antibodies targeting specific parts of the spike protein. There is animal data with the monoclonal antibodies showing that if you give it prophylactically, if you give it to the hamster or the rhesus monkey before you give the viral load, they both demonstrated, both in the hamster and the rhesus monkey, that post-infectially a decrease, an increase in viral clearance in those that were given it. In the hamster model, they get a bad ARDS and lung injury, and they were able to show prophylactically that had less lung injury if you had given it before they had been given their viral dose. There are currently phase 1, 2, 3 trials underway in humans. It's a novel strategy for studying. It has a 1-to-1-to-1 randomization with a low dose and a high dose. And there is phase 1, 2 preliminary data showing it had a decreased time to alleviate symptoms in those patients that were given it. Next slide. And then, of course, the last, and this is my last slide, is the monoclonal antibodies by Eli Lilly. They had the BLAZE-1 trial, 2 monoclonal antibodies combining, again, very similar to Regeneron, where they take 2 monoclonal antibodies at separate areas on the spike protein that don't overlap. And the reason to use 2 is so you could prevent resistance and mutations. The primary endpoint was a decrease in viral load by day 11. And they did meet their primary endpoint plus an improvement of symptoms. The BLAZE-2 phase 3 trial is currently underway. And then the NIH Active-2 and Active-3, the Active-2 trial is an Eli Lilly monoclonal, not the two combined of the BLAZE-1. And it's for ambulatory patients, not so sick patients, to see if they can prevent hospitalizations and further progression. And then the Active-3, which is the one that now has been put on hold, is for hospitalized patients. And again, there was a safety concern, so that one's been put on hold currently as they look. So that's kind of a quick overview of the latest literature on prevention of COVID-19. I'll turn it over to Dr. Smith, our colleague from the LSU School of Medicine.
Hi, everybody. Thanks a lot for giving me the opportunity to present some original research that came out of my group in the LSU Radiology Department out of UMC, where we practice, University Medical Center, New Orleans. I don't have any conflicts of interest. Next slide, please. So, on the background of that spike in cases that we're all familiar with, I want to remind you of the date of our Mardi Gras celebration, of our carnival celebration that happened in the late winter, early spring of this year. In 2 weeks between mid-February and late February, hundreds of thousands of people crowded into the streets of New Orleans. Of course, New Orleanians and people from Louisiana, but also people from New York City, other major places around the United States, and indeed all over the world. We have many hundreds and even thousands of international visitors. So we all packed into the streets, enjoying ourselves for a couple of weeks that end on Mardi Gras. Next slide. That was very unfortunate timing for us. because of what was going on with the virus. Not 2 weeks later, on March the 10th, in New Orleans, indeed at University Medical Center where I work, we had the first patient to test positive for SARS-CoV-2. Next slide, please. Now you have to remember that at this moment in time, we didn't have enough tests, and the tests that we did have were sometimes not as sensitive as we would have liked. Nobody really had a great idea what the sensitivity of the tests were. And also the tests took a long time to come back. We didn't have the 15-minute tests yet. So we were talking about 2-3 days, sometimes a week, for symptomatic patients to know whether they were actually positive. Now, during this period of time, a lot of the patients were getting chest x-rays. So we had lots of people pouring into University Medical Center, and everybody was getting chest x-rays. And my team of radiologists started to notice a very peculiar pattern on chest x-rays. So you see those arrows pointing to the white patches of opacity, the white patches of disease along the periphery of the lungs. We started noticing that this was happening a lot more than usual. We were seeing it much more frequently than usual. This isn't an unheard of pattern, but I might see it, I don't know, 5 or 10 times a year in a normal year, but we were starting to see it 5 or 10 times a day. And then in the moments when we were really spiking, sometimes several consecutively coming through the ER, a very unusual pattern. And so we said to ourselves, again, we didn't know whether these patients had COVID-19 because we didn't have the PCR tests coming back reliably and quickly enough. But we said to ourselves, this is too much of a coincidence. This chest x-ray pattern is coming way too frequently for it to be anything other than the pattern associated with COVID-19. So what we decided to do is try to do a little bit of study to prove that our anecdotal experience was worthwhile. Next slide, please. So we used our medical record and we analyzed all of the patients who had COVID tests in this 2-week period between March 13th and March 25th. This was, again, just as we had our slope rising. This was sort of when we had this ominous feeling and we knew that things were going to get very bad. We saw what happened in Italy and in other parts of Europe, and we were noticing that our curve was lagging behind theirs, but we knew where it was going to go. Next slide. So we took all of the patients who had PCR COVID tests, both positive and negative, everybody who was tested, who also had a chest x-ray that was done within 48 hours before the PCR test was performed. And what we got was 373 patients, unique patients with chest x-rays. We ended up with 376 cases where we had chest x-rays and PCRs that were obtained nearly simultaneously. And we blinded ourselves. The radiologists were blinded, and we decided to look in these cases to see whether that particular chest x-ray appearance was sensitive or specific or both for COVID-19. Next slide, please. Again, blinded to the PCR results, we assigned to each of these cases whether the chest x-ray was normal, that is, there was no abnormality on the chest x-ray, whether it was the characteristic chest x-ray appearance, which we had noticed, which we defined as bilateral patchy and or confluent band-like ground glass opacity or consolidation in a peripheral and mid to lower lung zone distribution. So those we called characteristic, and that's what we were really looking for. What does this pattern mean? And then in the middle, there was a non-specific category, which was basically any abnormal chest x-ray except for the characteristic pattern. So any abnormality that wasn't the characteristic pattern fit into non-specific. And then, as you'll see in a minute, we actually subdivided the non-specific category into a few different appearances. Next slide, please. So these were our results. Again, we did all the reading blinded to the PCR results, and you'll see in the negative radiograph pattern and in the non-specific pattern, including all of the subdivisions of that pattern, there's no statistically significant difference between those chest X-ray patterns between the PCR positive or COVID positive patients or the PCR negative or COVID negative patients. The only finding that was statistically significant, and you can see the p-value is highly statistically significant, was that the characteristic pattern showed up much more commonly in the COVID positive patients than in the PCR negative patients. Now, the sensitivity wasn't that high. So the pattern isn't extremely common in COVID, right? But it only showed up in 31 out of 200 cases. But the specificity was incredibly high, and the positive predictive value was incredibly high. So we thought that that was extremely useful, again, in an era when we did not have immediate testing results, or when we didn't have enough tests to know what was going on with the symptomatic patient. So these were very important results for us, and also very importantly, the kappa coefficient, or the inter-observer variability, showed an almost perfect relationship between the readers of the chest X-rays. And what that means in plain English is that any radiologist is going to agree on what the characteristic pattern is. Nobody's going to get confused and call a characteristic pattern nonspecific, and nobody's going to get confused and call a nonspecific pattern characteristic. Any radiologist, and indeed many other people who look at chest X-rays, will be able to distinguish these characteristic patterns when we see them. Next slide, please. So we were fortunate enough about a month and a half ago to have our work published in Radiology Cardiothoracic Imaging. You see my team of authors there. We were very happy that they put this paper out basically as soon as they got the final revision, and it was a couple weeks before they even added anything else to the volume. So they thought that there was some value in putting this out ahead of everything else. Next slide, please. And then we were equally proud that the American College of Radiology, which is our governing body, took this paper and put it in their list of clinical resources for COVID-19 diagnosis. You see the list there. Everything is a consensus statement except for this work that came out of our group, which is the only original research that the ACR has put on their page for diagnostic resources for COVID-19. So we're very proud of that. Next slide, please. That's the end of my presentation. The take-home point is that if you see chest X-rays like this, where you have patchy or confluent opacities in the periphery of the lungs, and COVID is circulating in the community, you have a very, very high chance of having found a patient who is COVID positive, and you can triage them and make some medical decisions on the basis of that chest X-ray, even if you don't have reliable testing at your fingertips. Thank you all very much.
Thank you, Dr. Smith. That's excellent and a great take-home. Next, we'll have Dr. Garcia Diaz, who leads our infectious disease research at Oxford.
So what I would like to do is sort of take you to some of the clinical trials that have impacted our clinical care. And so this slide sort of depicts the number of clinical trials that have occurred and how quickly things have, which is something that has been sort of typical of this last few months. So if you can see when cases first started, you see all of these clinical trials for COVID-19 in China, and then they're literally across the world throughout Europe, Asia, and the Americas. Next slide. So there are a number of therapeutic classes that are currently under investigation, some of which have had very negative results, somewhere in between, some that are still ongoing. So I'll try to cover some of those. So you see antivirals on the left-hand side, And then you have immunomodulators, and that's certainly not an all-inclusive list by any stretch of the imagination. There are multiple immunomodulators that are currently being looked at. And so some of those, I'll share data from those as well. Next slide. So, so this is just to illustrate the complexity of COVID-19 and the immune response that elicits into someone from the time that it's inhaled to the time that monocyte and macrophages are activated, the cytokine storm that occurs. And so a lot of the therapeutic agents that we're using are trying to sort of impact in some of these areas. And so as we look at those agents, they are targeting whether it's IL-6, whether it's IL-1, TNF, any of those. So, so it's a quite complex immune response that this elicits. Next slide. So the therapies that are sort of that have been shown to provide some benefit at different stages. And so you see here 3 different stages: early infection, and there are some that will not continue on to the next phase and will probably get better. You have those patients with low-grade fever and some dry cough, and they may exhibit some lymphopenia. Then you have those patients that are hypoxic, become short of breath, and show some of the chest images that Dr. Smith just shared with us. You'll have elevated liver function tests, and so on and so forth. And then you have those with cytokine storms that sort of just progress to ARDS, shock, and cardiac failure. And you see a number of inflammatory markers that are elevated on those patients. So at the bottom of the, you see some of the agents that have been used, and how do we determine these agents, and what is the best timing, what is the best place in terms of when should we start using any of those. So clinical trials are sort of focusing in these different types of clinical scenarios. Next slide. So this is Act 1. This was one of those that sort of impacted our care. So this was a multi-center adaptive randomized double-blind. So it was remdesivir versus placebo. And the assessments were, as you see there, all the way up to day 29. Patients that were included in this trial were greater than 18, and they were obviously hospitalized. And there were several findings that needed to be along with those. And infiltrates, and you know, it's sort of a recurrent theme because they are very typical of these patients. And every trial that we have done thus far has had to have chest X that show infiltrates as part of the criteria for entry. So you see here the preliminary results for over 1,000 patients, in which the recovery time was shortened from 15 days in the placebo arm to 11 days, and that was statistically significant. Mortality, there is a trend to lower mortality from 11.9 to 7.1, but that was not clinically significant. Next. So this is the trial that sort of kind of, is it 5 days? Is it versus 10 days? We usually start with more rather than less. And so is it 5 days enough? There are other studies that are looking at the outpatient, perhaps 3 days is okay for those, but these were hospitalized patients that had severe COVID. So these patients were randomized for remdesivir to receive 5 days or remdesivir to receive 10 days. These patients were hospitalized with severe COVID, and their PCR had to be within 4 days. And that's also a theme. Earlier is better. The longer a patient has had COVID, the worse the outcome, and there makes whatever you give it makes little impact at that point in time. So if you see the bar graphs at the bottom, so those patients that were on high flow oxygen, low flow, or even room air, it didn't make a difference whether they received 5 days versus 10 days. So now that perhaps for those that receive mechanical ventilation, that group of patients require farther studying. And currently, so that was sort of unclear whether there was a great benefit, and the recommendation is to remain at 10 days for those patients that are currently ventilated. Next slide. So this was also a trial that sort of impacted the care that we're doing. This is recovery, hospitalized patients with COVID, and this is very complex design. patients were randomized to usual care plus they either received no treatment or they received the multiple arms of different medications, and then they went on to have a simultaneous allocation to either receive convalescent plasma or not. And then if they progressed with a cytokine storm with this hyperinflammatory state, they were randomized to either receive no treatment or add IL-6 inhibitor. So 11,500 patients were enrolled. What happened with this trial, it was halted because the dexamethasone arm certainly exhibit a potential benefit. So the trial was halted. So next slide. So on the right-hand side, you see mortality in those patients that received the usual care was higher than the arm with the dexamethasone plus usual care, and that difference was significant, that was statistically significant. And then on the other side, on the right-hand side, the group that did not receive any oxygen support, there actually did not have any benefit in that population. There is a difference between the two, but that was not statistically significant. Next slide. So here is sort of where you see those patients that have received oxygen only, but they're not mechanically ventilated. The curves are a little bit wider in terms of those that get usual care versus dexamethasone plus usual care, but the highest impact in those patients that are mechanically ventilated. And you see that the curves are quite diverse in terms of sort of how different it is, and it's about 29% versus 44% in terms of mortality. Next slide. So this is to sort of summarize this. So the addition of dexamethasone to usual care certainly is associated with lower mortality, even when you see some of the subsets, and certainly is more impressive in those patients that are receiving invasive mechanical ventilation. There is no benefit in those with no oxygen support. Next slide. So this is the first trial that we participated in. It was Covacta, it was Actemra in patients with COVID. And this was using the tocilizumab in hospitalized patients with COVID-19 pneumonia. So this is probably the fastest trial that we have ever started. I think it was 2 weeks before we had it up and going. We enrolled the first patient in the US and the third patient globally. And so we were able to bring this to our patients. The results, there was about 489 patients that were enrolled in this clinical trial, and the results were not very encouraging despite the original reports from Italy that was quite useful. So we saw that there was no, in terms of the patients, in terms of improvement, there was no difference between the two arms. So the results were somewhat disappointing. Next slide. So then at the same time that Covacta was going on, halfway through that, and PACTA started, and that's evaluating minority patients with Actemra. And so this is currently not published yet. It will be in the preprint server. Hopefully, it'll probably be there tomorrow. It'll be available, and this just got submitted for publication, so we should hear fairly soon about the outcome. So this is a little bit different. So we tried to, so if you see on the right-hand side, 56% Hispanics were enrolled into this trial, 14% African Americans, and so there was a great deal to sort of invested in trying to see and enrolled and have a diverse population, which was not reflected in Covacta, which was the earlier trial. So the inclusion criteria for this was a much, it was a less sicker patient, if you will. Covacta was all comers, whether they were intubated or not. This was less than 6 liters of oxygen. So, and that had to be within 48 hours of admission to the hospital. So perhaps that's a lot of that needs to be teased out. Where is where is the IL-6 inhibitors better used in terms of outcome? So if you look here, you see that the proportion of patients with death or requiring mechanical ventilation is 12% with TOSI versus 19% with placebo, and that was statistically significant. There was very little change in mortality. It was 11 versus 8.8%, but that was not statistically significant. However, the piece that is hard to tease out of here is if you prevent mechanical ventilation, certainly you're adding to, you're lowering mortality, you know, you're lowering sort of that aspect of when we see that. We know that patients that get intubated, their mortality is quite high. So that piece, just preventing that, even though we see that the mortality itself in this trial was not impacted. Next slide. So I'm just going to cover a couple of things that Dr. Sawani covered, some of the monoclonals, and I'm going to focus on convalescent plasma. So that plasma that is recovered for patients that have had COVID, and we'll talk about the batch-to-batch variability. So next slide. So we participated in the expanded access treatment protocol that was sponsored by Mayo early on. And so this was a single arm open label protocol across 2,800 at the time that the data was accumulated. It has exceeded that. And the data was from April to July of 2020. Over 35,000 hospitalized patients were included in this analysis, and they were severe or life-threatening COVID. So 52% of those patients were in the ICU and 27% on mechanical ventilation. So although there is a high acuity in the patients that were enrolled, one of the criteria was that if the investigator felt like the patient would progress to have severe or life-threatening COVID, they were certainly could enroll the patient into the trial as well. 1 unit of plasma was transfused in the early part of the trial. There was an amendment that came after, and 2 units was mostly what patients would receive, but at the beginning it was 1 unit, and that's what's sort of included in this, those that got greater than 1 unit. And so the map there on the right-hand side sort of tells you all of the sites that participated across the US. So the rates in terms of 7-day mortality that was collected from the trial and 30-day mortality, so 8.7% if transfused within 3 days of the diagnosis versus 11.9% if they were greater than 4 days. And that was statistically significant, which goes to the same point, earlier is better. So those patients that we saw when we enrolled patients that had been in the hospital greater than a week, there was very little benefit from convalescent plasma. There was also a changes in sort of in the response when they had a gradient, if you will, with the titers. Not all places had the ability to sort of have plasma with titers. I know we did not at the beginning. So you had those that had high titers. Their mortality rate at 7 days was 8.9%. If you went to medium, it was 11.6%. And then you had a low titer, the mortality was at 13.7. So the higher the titer, the more benefit that you got from that. The findings at 30 days is very similar also as the 7, so that remained the same. Safety analysis, in 20,000 patients, there were very few serious adverse events, less than 1%. And so this data provides evidence that, you know, it's safe. And so looking at the numbers earlier is better. And so later there's very little benefit from that. Next slide. So, so we talk about how fast things are occurring presently. So this is comparing the vaccines. So if you look at the very bottom, you have polio, that from the time that polio was determined to be a viral illness, and it took about 60 years for the vaccine to occur. Then you got Ebola, it took about 15. And then you have SARS and MERS, for which we still do not have any vaccines. And then you have COVID-19. We'll probably see a vaccine somewhere between 12 and 18 months from where this had started, when it was first recognized back in December of 19. Next slide. So this is kind of superimposing the development timeline for vaccines. It takes about 3 to 8 years for vaccine design and animal studies. Then once you go through your phase 1, 2, and 3, it's about 2 to 10 years, and not to mention the licensing process takes about 1 to 2 years in addition to that. And if you see the timeline for the vaccines for COVID, it's going to be about 6 to 12 months. And so how everything is sort of compressed, this is the time scale that has been highly compressed. And we'll mention warp speed, and what we mean warp speed is exactly that, how this has been compressed with all of it has been a global effort to bring that to fruition. Next slide. So Dr. Swani mentioned this in terms of how many candidates there are in clinical development and how many in preclinical stages. There's a number of vaccines currently available. So you have in preclinical phase 1, phase 2, there are 5 currently being approved, but it was also mentioned that the data that is sort of happening, they're not getting the rigorous scrutiny for all, like we would for others. So we need to be careful as we get something for emergency use or to market. Next slide. So this was already mentioned as well. There are a number of vaccine platforms that we have: DNAs, RNAs, protein-based, virus vectors. We talked about adenovirus. So there are multiple different vaccine platforms with multiple technologies acting globally. And so most of there are all partnerships, and we need to sort of, we're not working in silo. We work sort of with all partnerships and collaborations across the world. So next slide. So these are the current vaccine candidates, and I only mention a few because there's no way to sort of be able to mention all of those. We are currently participating in the Pfizer vaccine. And so you see those on the right-hand side, Moderna and Pfizer, they are both messenger RNAs. And so Pfizer, we just completed our enrollment, 235 patients, and we're currently in follow-up. One of the things different about Pfizer than the other ones, they're going to start looking at children. So they'll start looking at 12 to 15, and they also look at 16 to 17. So they'll have that data. No one is having peds currently, so that's certainly something that our pediatricians, children always get left behind. So we'll have data at least for that population once this trial it's over. So the ones that you see on the left-hand side, you have AstraZeneca. We had issues with that, with patients with transverse myelitis. That's still on hold, as mentioned before. The other vaccine that we're participating is Johnson & Johnson. We are currently paused, and more information will come through in regards to what's going on and what was the serious adverse event that was that everybody has heard on the media. So, and then you have Novavax at the bottom, which is a protein-based, which is currently in clinical trials as well. So the ones that they have an asterisk by are those that are part of Operation Warp Speed and has had money infused from the government to try to expedite some of their development. So with that, I'll stop.
Thank you, Dr. Garcia-Diaz. Really good information. Our last speaker of the night, COVID has changed our world, has changed everything we are doing, including the way we train our medical students. I'd like to turn it over to Dr. Denton to take us through that.
Thank you, Leo. I'm going to go through my slides fairly quickly so we can get to the questions. It's very intimidating to follow Dr. Garcia-Diaz with her very dense slide deck and important information. Please move on to the next slide. So on March 17th, the AAMC issued this statement strongly supporting all medical schools to pause all clinical rotations effective immediately. And interestingly, at least until March 31st, that time period was meant to be used by schools to determine what we could do with medical students after having paused for 2 weeks to develop and implement appropriate programs to educate in the time of COVID. So Astra Health had already prohibited student interactions with COVID-19 by March 13th, so before that pause. And then we paused clinical rotations on Friday the 20th for a 2-week period of time. We shifted over some already planned downtime to cover this pause time. At the end of those 2 weeks, we gradually resumed face-to-face interactions. We were heavy on virtual learning at first. We continue to do mostly Zoom lectures. Occasionally, there are some lectures that go live, but most of them are Zoom right now. We implemented phone triage, and I'll get to that in a minute, and we implemented virtual rounding as well. So in some of our smaller team rooms, say on the surgical services and and particularly the neurology service comes to mind, we left the students at home and they rounded via iPads with the team to still participate in patient care when we began to resume face-to-face and rounding interactions. Can you go back? I wasn't quite ready. Sorry, I paused too long. We did full face-to-face interactions, first on peds and psychiatry because there was less disease on psychiatry and pediatrics. And absolutely, we still have a complete prohibition from student interaction with suspected or confirmed COVID-19 patients. During the pause, our students were sitting around and wondering what they could possibly do. 5 moderately large volunteer projects spontaneously arose at Astra Health. And I think these things arose at almost every medical school across the country. I can only speak to our experience because a lot of this hasn't been published yet. Our 5 programs were, our 5 biggest volunteer projects included a COVID-19 call center, a similar call center in the obstetrics department, standing up our PCR lab, our MedVantage clinic, and our family communication champions. Briefly, the family communication champions provided a bridge between our inpatient hospitalists who were taking care of a lot of these COVID-19 patients who were isolated in the hospital with no visitors, and our students took the communication from the providers to the families of our admitted patients to facilitate this communication. The providers were so busy they couldn't stop really to do anything other than take care of the patients. Far and away, the largest volunteer project was the COVID-19 call center. The existing outpatient nursing telephone triage line became rapidly overwhelmed. I remember a call on Saturday night that what can we do? And by Monday evening, we had stood up and implemented a call center where students could answer calls and do telephone triage. During the 2-week period, we had 109 of our 220 medical students who volunteered during this 2-week period. They put in 1,929 hours in the call center. They completed almost 2,000 patient encounters, which was 19% of the total calls during this 2-week period. So you can see how busy this was. The average wait time dropped from 18.5 minutes down to 1.01 minute after the students became involved. This next slide shows a couple of pictures of our students involved. You can see there's not much mask wearing here because they were clearly, this is before the mask standards. The students really worked hard. They were very, 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 very involved, and they were 6 feet apart while answering these phone calls. But this is before the mask mandate. The OB call center was very similar to the main COVID-19 nursing call center, but those nurses also became overwhelmed with calls, and many students volunteered over there, mainly our students interested in OBGYN. They joined this nurse triage line. The educational objectives were the same for both of these call lines. They were to improve effective communication with diverse patient groups, to be able to work within a multidisciplinary team. Many of our students had never worked directly with nurses in a triage situation. And as you can imagine, many students don't understand what it is that nurses do when they're talking to patients. So this gave them an invaluable view towards what our nurses are doing when they talk to patients at home. Students also gained skills in telehealth. It's None of these were video calls at this point. They were all telehealth or phone calls with patients. They were also able to practice clinical reasoning around problems during pregnancy and postpartum care in the OB call center, but also they could practice clinical reasoning around these the general patients who were calling in to the non-OB call line, determining who needs to go to the emergency room, who could come for a visit the next day, and who could go to the urgent care centers. So there were lots of competencies that our students could gain during this volunteer time, during this clinical pause time when students were not able to interact directly with patients. We stood up our PCR lab in-house. As has been mentioned earlier, there was and as most of you know, there was a long delay to get quick turnaround of PCR testing. The state testing labs were overwhelmed and very slow to return, frustrating to everyone, but it just was a function of the number of tests that needed to be run and the lack of testing platforms that were available. So Astra established an in-house PCR testing laboratory for COVID-19. We were fortunate that 2 of our students, including the president of the student body, had extensive expertise in running this very same machine when they did their PhD work. These 2 students, during the clinical pause, volunteered exclusively in this lab. And that is correct, 254 volunteer hours in a 2.5-week period. Without these 2 students, we would not have been able to stand up this lab. When we resumed clinical interactions, these students moved away from the lab and out into their clinical work as we hired more people and trained up enough people to do it. Now, that doesn't mean the lab didn't still want one of our students to come back and work all the time. But we had to put the brakes on that and send him back to his clinical work. But it really was very important to getting this going. The MedVantage Clinic is our primary care clinic that focuses on underserved, high utilizing patients who tend to go to the emergency room a lot and don't necessarily come to their primary care provider. Many of these patients don't understand the function of a primary care clinic or a walk-in clinic and see the emergency room as their outlet. So we have set up this MedVantage Clinic as a way to move these patients into better care in the outpatient setting rather than moving always into the emergency room. This clinic existed prior to the COVID outbreak, and students, many students volunteered there. They gained skills in patient communication, telehealth. They practiced screening for depression because that turned out to be a big issue with our patients during this period of time. And they were able to perform patient education on health issues, screen for COVID-19. They also trained our patients how to do virtual visits, which was something that we found very important early on in the COVID-19 pandemic attack on Louisiana. And we did a lot of virtual visits here, and these underserved patients were not particularly well suited to do this sort of training, do this sort of virtual visits. So we helped train these patients here. This is a high Spanish speaking clinic for us as well. And many of the providers and the medical students who worked here were Spanish speaking. Additionally, the regular work of a medical school has to go on as well. We were in the process of starting our interviews when the COVID pandemic hit. We had long done some of our interviews virtually because we have a national mandate, or we had more of a national mandate for admissions. And we shifted all of them to virtual, shifted from using one virtual interviewing format to the Zoom platform software. A tremendous amount of work, but we were able to do this with social distancing, disinfection of interview rooms between interviewees, and screening of interviewers prior to entry into the interview space. So we run 10 stations for our multi-mini interviews, and what we were able to do is seat the interviewer at a computer with a Zoom video conferencing software, and we moved the interviewees virtually from one interviewer to the next. We simultaneously ran 2 sessions at the same time, followed by 2 more sessions. So we pulled a lot of applicants through this interview session. By the end of June of 2020, we'd done 3 full days of virtual interviews and had run through 169 applicants, which is a tremendous amount of work, but very well received by the faculty and community members who did our interviews, and well received by the students as well. Both informal comments. I wish we had thought ahead and done some sort of wraparound IRB proposal to study this, but we missed our opportunity because we had to move quickly into doing this without a research project around it. So I said I would move through my slides quickly. I think all of us are open for questions at this point.
If you have questions, put them into the chat box, and I'll go up a bit. And says, one question was, were there Spanish-speaking people in the call center?
Yes, there were Spanish-speaking people in the call center. Most of the nurses who always take this, who have traditionally taken these calls, were Spanish-speaking, and we had several Spanish-speaking students there as well.
All right. Then there's a from one of the Ochsner UQ medical students says, "Thank you, Dr. Denton, and the whole admin team at Ochsner. They've done a fantastic job finding a safe path for the medical students to remain fully engaged on and off the wards during the pandemic. While we don't see COVID patients, being back on the wards and discussing COVID and its sequelae with our attendings has been an invaluable part of medical education."
Thanks, Luis. It's great to hear that comment. We've tried to be very careful to keep you guys safe while still continuing your medical education. I think we monitor symptomatic students and students who've had exposure. We've had up to 12 students out with exposure at a time, but currently we're running about 2 to 4 exposed. We haven't had any student hospitalized with COVID-19. And you know, students run into COVID-19 in the community just like the rest of us do.
A couple of questions. Has there been any data to suggest that immune-compromised patients, such as transplant patients, have been more vulnerable to the COVID? The answer to that is yes. The CDC does list immune-compromised patients as an increased risk group for more morbidity and mortality. This one's for you, Ben. This is great information. Will the slides be available on the Ochsner website? Is it possible to provide the URL for the Ochsner site to receive CME? I guess that's to Melissa and Ben. I guess the answer would be yes.
Yes, the slides will be available on the NHMA website, nhmamd.org, and on the chat, we have the link to claim the CME.
Right. I don't see any new questions. While we're waiting for new questions, I would be remiss to say, to thank Dr. Claudia Medina. She's the co-chair for the Gulf Coast National Hispanic Medical Association, and she really put this fine group of speakers together, along with Melissa Johnson, who is just expert at everything and makes everything happen. And I would not know what I would do in my life without Melissa Johnson. So thank you, Melissa. Thank you, Dr. Medina, for all the great work putting this expert panel together and this event tonight. Right. Well, it's late on the Eastern Time Coast and on the Central Time Coast. I want to once again thank all those who joined us live for the conference. I think we had approaching 40. We will record this. I also want a great thank you to all our esteemed speakers tonight. Appreciate you taking some time away from your family to share this valuable data with our colleagues. Ben, any last words on your part?
No, we're all good. Thank you so much, everyone, for joining us.
Thank you. Remember, mask up and stay safe.